Let us now learn about what happens when there is lesion to cerebellum. Based upon where the site of lesion is, the presentation may vary. Let us begin with the midline lesion to the cerebellum. This is most often due to medulloblastoma and it is seen in young children, and it will result in truncal ataxia. So here there is a 3-year-old child brought to the hospital by the parents with complaints of headache and frequent falls when the child is attempting to stand. And child always prefers using some support during standing. Usually a child is able to stand independently by end of 1 year, and standing and moving around becomes easy as the child progresses through 2nd year. But here there's a 3-year-old child still preferring to use some support while standing. Fundoscopic examination revealed papilledema, again a sign of raised intracranial tension. The presenting features will be truncal ataxia, that is, patient is unable to maintain upright posture until and unless patient uses some form of support. That's because of the disruption of connections between vermis and the vestibular nuclei. Patient may show nystagmus. That's again because of the disruption of connection between labyrinth and the cerebellum. And when we follow the eye movements, it will be revealed that the patient has inaccurate saccadic movements, impaired smooth tracking, and fixation anomalies of the eyes. That is because of the disruption of connections between cerebellum, vestibular nuclei, and with the third cranial nerve nucleus and the gaze centers, which is done through the medial longitudinal fasciculus. So main symptom here is patient is unable to hold an upright posture without supporting. The second type of lesion is the anterior lobe lesion that will result in gait ataxia. So here is a 60-year-old alcoholic patient brought with complaints of frequent falling. On examination, he exhibited a broad-based gait with lurching. Now, if the lesion is unilateral, usually the lurching or reeling is to one side. Otherwise, the patient will be lurching from side to side. By the time the patient exhibits these symptoms, he will have lost about 10% of the granule cells in the cerebellum, 20% of his Purkinje cells, and close to 30% of thickness in the molecular layer. This whole thing is because of the disruption of connections between anterior lobe, nucleus interpositus, reticular formation, and reticulospinal tract. So it is classically described as staggering gait. Patient will also be unable to perform tandem gait, that is, ask the patient to walk in a straight line by putting one foot forward in front of other in such a way that the heel of the forward foot should be touching the toes of the foot at the back. So when he tries to walk in that fashion, he usually sways either to one side or to both sides. The other feature of gait ataxia is deep tendon reflexes will be depressed. The third type of lesion is the neocerebellar lesion, resulting in ataxia. Now here the lesion could be to the cerebellar hemispheres, especially the posterior lobe part, or it could be lesion to the dentate nucleus, or it may involve lesion to the superior cerebellar peduncles. So based upon this, the lesion may be localized within the cerebellum, that is, if it is affecting cerebellar hemispheres or dentate nucleus, or it may be involving pons or midbrain, because superior cerebellar peduncles will be in relation to pons and midbrain also. So lesion could be involving those parts of the brainstem. The main presenting feature is the ataxia or incoordination of voluntary movements, where the movements become imprecise, clumsy, and halting. That's because of the errors in direction, force, and speed of the movements. However, with time, patient observes that is better recovery. That's because of the double mirror representation of the body in the cerebellum. The neocerebellar lesion can be detected by eliciting a series of cerebellar signs by performing various bedside maneuvers. They're very interesting and easy to perform. So let us go through them one by one. The patient has Aesthenia or reduced resistance to passive movement. Now this is elicited by simply taking the patient's forearm and trying to flex and extend at the elbow, or flex and extend the hand at the level of wrist joint, you will find that there is very little resistance offered because of the hypotonia there, and muscles have also become weaker. Secondly, the patient has Dysdiadocokinesia, that is inability to perform rapid alternating movements. So this rapid alternating movement requires very precise coordination of the muscles. That is again governed by the cerebellum. In case of lesion of neocerebellum, patient will be unable to perform this. So how do you test this? Just ask the patient to perform rapidly alternating movements like supination pronation, closing and opening of the fist, or tapping his fingers on a surface to create a music, or even tapping of the foot if you suspect that the lesion is affecting only lower limbs. So patient will be unable to perform this rapid alternating movements. Most commonly it is tested by doing supination pronation alternatingly at a high speed. Then we have what is known as rebound phenomenon. When a normal person is performing a particular activity against resistance, when the resistance is removed, that activity can be halted almost immediately. But in case of person with cerebellar lesion, the person continues to move in the direction even after the resistance is removed. Now this is tested by asking the patient to flex his forearm against resistance. So as a physician, you offer resistance for flexion of the forearm by putting your hand in front of the forearm. Ask the patient to flex his forearm. So when the patient is trying to flex, just remove your hand. Normally the patient should stop flexing it in and around that time. But in this case, the patient will continue to flex, but make sure that he doesn't go and hit his face when the rebound phenomenon is exaggerated. Next, there is usually these people with neocerebellar lesion will show hypotonia. That is again tested by performing knee jerk. In a normal person, when you tap the ligamentum patellae with the knee hammer, there is a simple extension of the leg one time. But in case of a cerebellar lesion, when you do this knee jerk, when you elicit this knee jerk, the leg continues to extend repeatedly, forming a pendular knee jerk response. This is again a classic sign of cerebellar lesion. There is decomposition of movements. Cerebellum helps in performing any movement in a smooth fashion so that the movement will occur in a continuous sequence. Whereas in case of lesion to the cerebellum, the movement is broken into multiple components. So ask the patient to pick up an object from table. A normal person would pick it up in one continuous movement. Whereas when you ask the patient to pick it up from the table, he first moves his shoulder, then followed by elbow, then movement at the wrist, then at the fingers, then picking up and back in the same direction. So it is broken down into multiple components. That is what is known as decomposition of movements. Patient shows intention tremors. This is a sign of neocerebellar lesion. We have already discussed this in relation to postural fixation. When you ask the patient to do an act, as the patient approaches the target, the hands will show coarse and rapid tremors. That is what is known as intention tremors. You can exhibit this by asking the patient to pick up a pen, button a shirt, or even open his wristwatch. You will see that the hands shake rapidly and in a coarse fashion. That's as the patient nears the pen or shirt button, or in case of removing a wristwatch, as he nears the wristwatch. Patient also shows static tremors. These are actually more of a sign of midline lesions or anterior lobe lesions, but even the neocerebellar lesion patient, if you ask the patient to hold his arms outstretching in front of him in such a way that the arms are parallel to the ground, soon you will find that the proximal part of the shoulder muscle, that's muscles around the shoulder, will show the tremors that will result in passive tremors or the static tremors. That's again a feature of cerebellar lesion. Patient exhibits dysmetria, or what is known as past pointing. Normally, when you are performing an act, you will reach precisely where your fingers are intending to move or where fingers are intending to reach. Now, this ability will be lost in a patient with cerebellar lesion. So this can be tested simply by asking a patient to perform finger-nose test or finger-finger test, or for the lower limb, shin heel test. So how do we perform this? You hold your finger in front of the patient, ask the patient to use his hand to touch your finger with his finger, and then go back and touch his nose. So you will see that both times when his patient is coming to touch your finger or goes to touch his or her own nose, the hands will go beyond the point and go and touch an area much beyond the target area. That is what is known as past pointing. Of course, this is super added with action tremors as well. In case of finger test, you ask the patient to outstretch or abduct both his arms and bring them close to the midline where the finger of the right hand will touch the finger of the left hand. Again, here there will be past pointing. They go beyond the two hands. Shin heel test we perform by asking the patient to take the heel of one foot and trace it along the shin of the other leg. Again, he'll be unable to do it in a smooth fashion. He'll go beyond that point. So these are the tests performed for dysmetria. You will notice that how important cerebellum is in case of performing some of the sports. Now think of a player playing tennis or badminton or even cricket or table tennis. If in case he has dysmetria or past pointing, he or she will never be able to win a game. Now, patient shows staggering gait. Again, most commonly this is a sign of anterior lobe lesion. Even in case of the neocerebellar lesion, the gait will be broad-based, and because the patient is trying to coordinate the movement. Romberg sign, which usually is taught in the clinical side, that with the eyes open, the patient will be able to stand without swaying in case of posterior column lesion. But when the eyes are closed, if there is a lesion to the posterior column, then the patient will sway to the side of the lesion. However, in case of cerebellar lesion, whether the eyes are closed or open, the patient sways to the side of lesion. But however, it's now known that Romberg sign, the whole pathway includes only the posterior column, vestibular apparatus, and the visual pathway. It does not actually say that there is a lesion or no lesion in cerebellum. However, we can test the tandem walk, that is walking the straight line by putting one foot in front of the other so that the heel of the forward foot touches the toes of the foot at the back. Now here, the patient will reel to the side of the lesion with eyes closed or open. That is a definite sign of cerebellar lesion. You can also observe the patient's posture. Usually with unilateral lesion, the patient's head will be bent and shoulders will be drooping on the side of the lesion. Patient demonstrates titubation, that is, when the patient is sitting in a place, there will be tremors observed in the head and body. Usually these are rotatory bobbing movement or rocking movement, again seen on the side of the lesion. Patient shows a typical way of speech known as scanning or staccato speech. So he shows this dysarthria. Ask the patient to say artillery. Instead of saying smoothly artillery, he say artillery. So he'll be stressing on certain syllables. Same thing can be demonstrated by asking the patient to say British Parliament. Again, British Parliament. So the stress will be at different syllables. You can also ask the patient to repeatedly say la 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 or me. Now this is for testing the same thing what we were doing for Dysdiadocokinesia in case of upper limb or foot tapping for the lower limb. Here we are testing the movement of the tongue by asking the patient to say la 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 repeatedly or me repeatedly for the muscles of the lips. Again, the patient will be unable to do that. Patient demonstrates horizontal nystagmus with the fast component to the side of lesion. So the classic Charcot's triad includes horizontal nystagmus, staccato speech, and intention tremors, all the three of which will show that there is a lesion to the neocerebellum. So by just performing these various bedside tests, one can confirm that there is lesion to the cerebellum. Then there is a condition called as cerebellar cognitive affective syndrome. Here, though there is deficit in the though there is lesion in the cerebellum, the deficit will be in the cerebral higher functions. So patient will show deficits in executive functions like planning, verbal fluency, abstract reasoning, and attention. He may have deficits in spatial cognition, like visuospatial organization will be lost, visual memory will be lost. He may have deficits in his emotions like blunting of affect or inappropriate behaviors. This is specifically seen when there is involvement of vermis. And the patient may show certain language disorders like agrammatism. So you will know that all these functions are actually executed by cerebral cortex, but they will be affected in a cerebellar lesion, especially when the lesion is large. And lastly, we have what is known as cerebellopontine angle tumor. Now this is the cerebellopontine angle. So here we have a 40-year-old patient, lady coming to the OPD with complaints of tinnitus in her left ear. Tinnitus is basically ringing or whistling sound in the ear. ENT examination revealed normal ear findings. However, neurological examination revealed features of left facial palsy as well as nystagmus. An MRI confirmed a tumor at the cerebellopontine angle. So what are the structures here at the cerebellopontine angle? We have 7th cranial nerve present there. That is why the compression of the tumor the compression of the 7th cranial nerve by the tumor will result in ipsilateral facial palsy symptoms. 8th cranial nerve is located there. So compression of the 8th cranial nerve by the tumor will result in either tinnitus or deafness or vertigo and nystagmus. Middle cerebellar peduncle and the brainstem here will be surrounded on either side by cerebellum. So compression of the middle cerebellar peduncles or cerebellum will result in features of ataxia. And there is foramen of Luschka, which is one of the ways by which the CSF within the ventricle will escape into subarachnoid space. So that may be blocked, that will result in features of hydrocephalus. So these are the features of CP angle tumor, but most often the patient comes with an innocuous symptom of tinnitus or mild deafness in one of the ears. Only when we do further examination that we can confirm the CP angle tumor. Thank you very much. Hope you enjoyed this video. You can visit this site for other videos on neuroanatomy. Thank you.